Hi, it's Lena here again. You're watching this video because you've been instructed you're a candidate for a hip arthroscopy. So we're going to go through a little bit of the anatomy and what the potential surgical procedures that you're going to be getting, so you'll just be a little bit more informed. When you think about the hip is a ball and socket joint. On the socket side, there's a labrum that circumferentially goes around the hip. That can get pinched, and it oftentimes does get pinched if you're ligamentously lax, so that increased mobility enables you to pinch that labrum and cause a tear in the labrum. You can also get some cartilage irregularity, which could be delamination if you have an impaction injury. If you're in a motor vehicle accident and the hip impacts into the acetabulum, you can sometimes disrupt the cartilage, so it delaminates, just like your linoleum floor. It peels up, and that can catch on you back and forth as you move. You can also get synovitis inside, and sometimes you can get a stiff capsule, like an adhesive capsulitis of the shoulder, but a stiff capsule in the hip. People always also complain about trochanteric bursitis. So the band of tissue that comes across from the iliac crest, across the trochanter, and then across the knee as well, that band can snap forward and snap back, giving you discomfort on the side of the hip that radiates down the leg. The majority of treatment for this is non-operative, and you'll see our videos on how to stretch out the trochanteric bursitis in the physical therapy section. But for the surgical intervention, when you're a candidate for the hip surgery is after all of the conservative modalities have failed: physical therapy, stretching, rehab. We oftentimes do give injections into the joint, both as a diagnostic and therapeutic tool. It's diagnostic because if we inject it into the joint and the pain goes away, we know that that's the source of your pain, because there are extra articular sources of pain that we need to identify as well. And also therapeutic, because if it can calm down the synovitis associated with your labral tear, then you can hopefully treat it conservatively. There are external factors that can cause pain as well, and that's snapping hip, coxus saltans. The band of tissue, the iliopsoas, comes across the anterior aspect of the acetabulum, and then it goes down into the lesser trochanter. And with motion back and forth, you can sometimes get a snapping back and forth. And oftentimes people think that is a labral tear, but it's really a coxus saltan snapping hip. And we can address that conservatively, usually with stretching exercises for the hip flexor and iliopsoas. And occasionally we do have to do a surgical release of it, where we'd either do an arthroscopic approach and then release that tendon in the front of the hip, or if it's after a total hip replacement where the cup is a little bit proud and it rubs against the cup, it can cause chronic inflammation. In that case, we would release it off of the lesser trochanter to try and decrease the stress on the anterior aspect of the capsule. For labral tears, I usually use just two portals, so it's arthroscopically guided, two small poke holes inside the shoulder, inside the hip. We release the capsule so that we can better visualize throughout the hip, and then we either repair or remove that offending part of the labrum. We prefer to repair the labrum, but if there's no good blood supply to it, no matter how many sutures I put in it, it's not going to heal. So we will make that determination at the time of the surgery, whether to remove it and allow you to keep living without it, or to fix it, which is a longer rehabilitation, but we'd rather do it and give you the preservation of that hip. There's also surgical procedures that we can do on the outside of the hip. When you have chronic trochanteric bursitis and you've failed all conservative modalities, and we usually wait a year, year and a half prior to the surgery, we can arthroscopically go in to the top of the trochanter and ellipse out that band of the IT band. What that does is that creates an opening. We leave the anterior and posterior band intact, so you still have the strength of the IT band, but it doesn't snap back and forth across the trochanter. We sometimes will also do that ellipse if there's an abductor tendon tear. The abductor tendon is what helps you stand on one leg. So if that is truly the case, we would ellipse out that band of the IT band, and then we'd go in and repair the abductor tendon into position to enable you to stand more strongly. So that is a brief description of the surgical procedures around the hip that are most commonly done. Feel free to come in and talk to us prior to any surgical intervention, but we'll see you in the OR at some point in time.